First of all, I would like to thank the organizing committee, in particular Dr. Yudi Herr Octaviano, for giving me the honor to take participation in this very important meeting. I am assigned to deliver a talk on state-of-the-art lab-made publication, PCI. I have nothing to disclose. These are 5 very important documents. First is the 14th and the 15th EBC consensus on bifurcation, and also consensus on intracoronary imaging by EFC and also by EBC, written by Gary Mintz and colleagues, and also the 2018 ESC-EX guideline on myocardial revascularization. The topic is when to treat lab-made bifurcation stenosis. So indication for this is as follows. Patients with angiographic stenosis of more than 50% and documentations of myocardial ischemia. However, in clinical practice, evidence of myocardial ischemia can be equivocal, and lab-made disease is sometimes difficult to assess with coronary angio because of lack of appropriate angiographic views, possible absence of undiseased reference segment, and interaction with the intubating catheter and so on. So we need also IFUS, and we use the cutoff of less than 4.5 as to indicate the severe lab-made stenosis, and also FFR of less than 0.8. However, integrated use of functional assessment and imaging for lab-made PCI is of utmost importance. So I would like to share with you some of the very important clinical studies, and this is the meta-analysis of IFUS versus angio-guided PCI for lab-made disease, showing here that if we use IFUS, we will reduce mortality, cardiovascular mortality, stent thrombosis, myocardial infarction, and target lesion revascularization. This is the most recent meta-analysis of 11 lab-made DES study published just recently in this year. And therefore, the 2018 ESC-EX guideline recommend IFUS to be used to optimize stent implantations, and for unprotected lab-made lesions, IFUS should be considered to optimize treatment. So this is the recommendations of EFC, just recently published also, the role of MLA assessment in the evaluations of lab-made coronary artery disease. If the MLA is more than 6, we can treat the patient conservatively with optimal medical treatment. If the MLA is less than 4.5, we have to revascularize either PCI or CABG, whereas in between, we have to consider physiological assessment. So this is just to show meta-analysis of physiological assessment using FFR, showing here that for ambiguous lab-made stenosis, for whom revascularization deferred on basis of FFR, result is favorable and very similar to the revascularized group in terms of combined endpoints, death, myocardial infarction, death, and so on. So this is just a flow chart to show how we should use a physiological assessment in patients with lab-made disease. If the values are on both sides, LAD and LCX, less than 0.8, then we need to do revascularizations. If the results on both branches are more than 0.8, then we have to put the patient on optical medical treatment. If the result is discordant, we need to do PCI or CABG also. We have to treat the largest step up and then repeat the pullback until FFR is more than 8.8. Otherwise, we can also use IFUS using MLA of less than 4.5 as cutoff. We can also use IFR for revascularization deferral in patients with lab-made, and with IFR, it is pretty safe to defer if the result is still acceptable. In terms of composite endpoints, death, myocardial infarction, TLR, all-cause death, non-fatal myocardial infarction, and TLR. So this is the ESC recommendation in 2018 regarding functional tests of intravascular imaging. When evidence of ischemia is not available, the use of functional assessments are recommended to assess the hemodynamic relevance of intermediate grade stenosis. So now regarding the importance of angle, we have two types of angle: T-shaped angle, which is more difficult to assess side branch, but with this angle we will have a less plaque or carina shifting. Y-shaped angle is easier for us to access the side branch, but we will have problem of more plaque or carina shifting. For the T-shaped angle, we can apply T-stenting or tap procedure and not Y in the Y-shaped angle. Whereas in the Y-shaped angle, we can apply the crush, culotte, SKS or mini crush technique, but we can use DK crush technique for both types of angulations. So we also need to know the overexpansion limit of our stent, because if a lemon is a very big vessel, if the stent is not well opposed, then we will have problem with stent thrombosis or restenosis. But if the stent is overexpanded, then we may have a problem of stent fractures and also plaque prolapse, because of the stent cells will be oversized. Shown here that overexpansions may cause straightening of the stent struts and widening of the struts, and this may induce plaque prolapse and also incomplete or insufficient drug distribution, especially in the center of the cells. So we have to consider this. We can also use IFUS to assess results of our stenting procedure. We can apply the rule 5, 6, 7, 8, because if we have, we can get these results. The restenosis rate is less than 5%, TLR is less than 2%. 5 represent the MSA, the LCX, 6 LED, 7 polygon of confluence, and 8 in the left main. And then regarding the technique, of course, a very popular technique is the professional stenting strategy, the so-called stent crossover technique. But in the ESC AX 2018 recommendations, in true bifurcation stenosis as shown here of the lamine, DK crush technique may be preferred over professional stenting strategy. This is the DK crush technique. And this is the algorithm. If we have pseudo lamine bifurcation stenosis, we may opt to use a professional stenting approach. And if the result is excellent, we finish the case. And if the result is suboptimal, we can use FFR on IFR to measure the significance of side branch pinching. And then depending on the result, we may finish or do a final kissing balloon dilatation of this stenting procedure. Whereas if we are facing patients with true bifurcation stenosis, especially complex bifurcation stenosis, we have to use two-stent strategy and use the formula 5, 6, 7, 8 to assess our result. This is another criteria for optimum result based on IFUS for distal lamine bifurcation stenosis. Can be applied for patients undergoing professional stenting strategy or two-stent techniques. You'll see here we need to have a MSA of more than 90% in the reference vessel, left main, LED or LCX, and also complete stent apposition, no proximal stent deformation, and at the stent edges, plaque burden should be less than 40%, and there is absence of dissection or hematoma. If we apply this technique, as shown here in the clinical study, red line, this is Kaplan-Meier curve, indicates those who satisfies that criteria. The result is much better as compared to those based on angio assessment only. With respect to primary endpoint, pre-survival curve, primary endpoint is defined as composite death, STEMI or non-STEMI and TLR, and also for TLR-free survival curves. So we can apply this in our patients. So we need also to know what is defined as complex bifurcation stenosis. For left main, we need to have one major criteria, and that is side branch diameter stenosis 70% or more, lesion length of 10 millimeter or more, in combination with two minors. And minor criteria include more than mild calcifications, multiple lesions, bifurcation angle of less than 45% or more than 70%, and main vessel reference vessel diameter of less than 2.5, main vessel lesion length of more than 25, and thrombus containing lesions. Complex bifurcation lesion is defined as one major plus any of two minors. And this is a step-by-step technique of DK cross technique. I don't want to elaborate this more in detail because I do believe that all of you already know this wonderful technique. And this is just to show the result of the DK cross 5 randomized clinical trial. DK cross as compared to provisional stenting strategy in left main bifurcation lesions. And you'll see here for simple lesions, the result is in favor of DK cross in terms of primary endpoint target lesion failure, and result is even better in patients who has complex lesions. Here, the DK cross is much more superior as compared to provisional stenting strategy in terms of primary endpoint target lesion failure. So this is another clinical study, definition 2 trial, using the same criteria for complex lamina bifurcation stenosis, showing here that DK cross is indeed superior to provisional stenting strategy in terms of TLR, target vessel myocardial infarction, and target lesion failure being significantly better in the DK cross arm. I just want to share this case, double DK cross for double bifurcation stenosis. Patient has significant stenosis in the obtus marginal LCX branch and also in the distal left main. And then after stenting the proximal LAD, we put a stent in the obtus marginal and then crushed the stent, did the first kissing balloon dilatation, the LCX obtus marginal, stent the LCX, did the stent crushing, and then did the first kissing balloon dilatation at the left main bifurcation site, stenting of the left main and LAD, second kissing balloon dilatation at the left main bifurcation, and did POT. And then this is the final or second kissing balloon dilatation of the LCX obtus marginal, and then finish the case with another POT in the left main and obtain good result as shown here. And this is in the lower panel, no restenosis at 1 year follow-up. Excellent result. So showing that DK cross did a very good technique. This is the second case, male patient, 70 years old, presented with STEMI, non-STEMI, and also heart failure. He also has a chronic kidney disease, stage 3. ECG showed widespread SG changes, and the CAT showed Lemon triple vessel disease. Is in high risk for PCN, also CABH, but he declined surgery. And this is the angio showing left main bifurcation stenosis, true left main bifurcation stenosis, Medina 111, with heavy calcifications here in the LAD down to the distal LAD here, and also multiple stenosis in the LCX and also in the left main and the obtus margin. The RCA is completely occluded. So after pre-DIL, we stent the obtus marginal, and then we attended the LM LAD, but one spot here was resistant to a balloon dilatation here in the LAD, and the IFR showed diffuse disease in the LAD, and there is a remarkable step up here which represents this resistant spot here in the proximal LAD. Our IFS catheter could not cross, so we have to do orbital atherectomy, and after 8 runs, all lesions yielded to balloon dilatations. And it's just to show the IFUS. You'll see here that even in distal left main, you see calcifications. This is at the bifurcation site. And then we have also calcification all over until the mid LAD. And you'll see here we have introduced cracks, and in some parts close to napkin ring calcifications, we have also introduced dissection cracks. And this means that we already have a good platform for our stent, and this is the first stent implanted the proximal LAD, and then we attended the left main bifurcations with two stents, one less LCX in the left main, did proximal site optimizations, first kissing balloon dilatations, and then stent the left main LAD, second kissing balloon dilatation, and finish the case with spot. And then we achieve a good angiographic result as shown here. And then this is the AFOS also showing excellent result, stent well opposed, well expanded, no edge dissection, no proximal stent deformation, and MSA was more than 90% of the proximal reference of the respective vessels. So this is to show the functional assessment, left main LAD and left main LCX, showing here that at the baseline, the QFR is subnormal and became normal after the procedure. So this is the last case, female, 50 years old with crescendo angina, and she had the positive treadmill test, and left main showed left main triple facial disease. She's in a high risk for PCI and slightly high risk for cabbage according to the scoring system, and she declined surgery. And this is to show the angio. Here, distal left main bifurcation stenosis, Medina 111, heavily calcified diffuse disease in the distal left main and also proximal LAD, and significant stenosis in the proximal X. And RCS also disease, but we didn't show it. As the lesion was too tight, lesion preparation was performed before OCT imaging. So we used ROTA, 1.5 millimeter burr was used, and after several runs, the patient developed chest pain, blood pressure dropped, and ECG showed ST elevation, and angio showed diffuse LAD spasm, as you may appreciate here. So after balloon dilatation, to reconstitute flow, we obtained better flow in the LAD and associated with improved hemodynamics. And this is a OCT pullback after rota balloon pre-stenting and save time. I just want to show you this cut images showing here good left main. And at the bifurcation side, you'll see here calcifications. This is the circ. And then a lot of calcifications in the proximal and mid LAD. Calcium volume index was 4, and you will see here polished concave surface, calcium cracks, and dissections as a result of combinations of rota and balloon. And then, of course, after this, we believe that we already have a good platform for our stent. We use GuideLiner to assess our stent implantation, the proximal LAD. And then we fixed the left main bifurcation site with two stents. Initially, we implanted a stent left main LCX, did stent crushing, first kissing balloon dilatation, stent the left main and LAD, second kissing balloon dilatation, finished the spot. And we achieved very nice angiographic result as shown here. And this is just to show the stent rendering mode of the OCT pullback from the left main to the LAD. Again, here you will appreciate that the overlapping stents were well opposed. This is the overlap zone, and very nice result without edge dissection. And this is to show the cut images, again confirming the well-exposed, well-expanded stents in the LAD and LM. There is only minor dissection here in LM, which is of no clinical significance. And this is the stent rendering mode, showing here the OCT pullback images, image of left main, LCX to left main. Again, very satisfactory result. And this is the QFR assessment of the left main LAD and left main LCX, showing subnormal value at the baseline, which became normalized. So in conclusion, Provisional stenting strategy can be applied for the treatment of pseudo-lamine bifurcation stenosis. The philosophy of making complex matters simple may not be necessarily true in PCI of complex lamine bifurcation. True complex bifurcation lesions with the criteria established in the definition study is better treated with two-stent strategy, which may yield lower TLR, TLF, and target vessel myocardial infarction. PK cross-technique, as endorsed also by the 2018 ESC EX guidelines, is an excellent strategy for the treatment of true lamine bifurcation stenosis. Use of intravascular imaging and functional assessment in combinations with better technique, devices, pharmacotherapy, patient selection, and operator experience may further improve the short and long-term outcome beyond what is reported in randomized clinical trials. So I thank you for your comment. First of all,
Baik, dengan selesainya presentasi dari Profesor Santoso, maka kita sekarang memasuki session untuk diskusi. Tadi kita sudah mendengarkan dua sesi pembicara yang sangat menarik dan sangat memukau. Maka kita sekarang bisa buka untuk acara diskusi. Kembali panelis kita hadir, Dr. Sunaria, Dr. Budi Bakti, Dr. Urus, kemudian Dr. Amir Aziz dan Dr. Erwin Saleh. Baik, saya persilahkan kepada para panelis. Dr. Erwin, mungkin ada suatu komentar atau pertanyaan.
Baik, terima kasih. Saya hanya ingin bertanya sedikit kepada pakar-pakarnya, ada Prof. Santoso dan Dr. Munawar. Apakah dalam keseharian dokter pada PCI CTO ini, kita tahu bahwa CTO ini kan hanya symptom relief dan meningkatkan quality of life. Jadi apakah sebelum tindakan, apakah dokter sekalian melakukan suatu viability study misalkan pada pasien-pasien, apakah hanya tergantung dari EF yang kurang dari 30 atau dokter hanya melihat dari ekokardiografi cukup. Saya rasa pertanyaan saya ini mungkin penting bagi teman-teman kardiologi di seluruh Indonesia ketika mereka akan merujuk, oh ini CTO, apakah saya akan rujuk dan apakah pasien yang saya rujuk ini worth it atau jauh-jauh datang ke kota besar untuk melakukan CTO intervensi. Terima kasih, Dok.
Ya, terima kasih, Dr. Arwin. Untuk perfusion study tentu saja tidak semuanya. Pada pasien-pasien yang katakanlah ejection bagus, ada RWMA, kemudian ada simptom, treatment test positif, tentu saja kita bisa langsung melakukan. Jadi sebenarnya setiap tindakan, tadi dalam slide saya sudah jelas, tapi sebenarnya semua tindakan, apakah itu situ atau bukan, kita mesti harus ada risk, benefit, kemudian ada safety atau tidak, cost dan sebagainya. Kalau itu misalkan benefitnya jelas, risk-nya kecil, success-nya 100%, ya pasti harus kita lakukan. Karena risk-nya kecil. Tapi kalau misalkan risk-nya besar, lalu suksesnya susah, benefit-nya kecil apalagi. Jadi kalau benefit-nya besar, meskipun risk kecil, tapi kalau prosedurnya menurut kita bagus berdasarkan scoring system, berdasarkan pengalaman kita, CTO-nya pendek, ya bagi pemula CTO-nya pendek, taper dan sebagainya, saya kira sih kenapa tidak gitu. Apalagi kalau cost-nya tidak begitu besar. Tapi kalau cost-nya besar, udah CTO-nya panjang, kalsifikasi, lalu apa lagi, distal targetnya nggak ada, kolateralnya nggak bisa, Jackson Factor rendah, ya tentu saja tidak. Jadi berdasarkan tentu saja tidak bisa dengan hitam putih, ada yang daerah abu-abu yang mestinya kita. Tapi paling tidak harus ada benefit yang jelas. Success rate-nya menurut kita cukup baik. Perfusion scan barangkali sih dalam keseharian mungkin tidak saya lakukan asal masih viable. Kecuali kalau misalkan Jackson rendah dan sebagainya, itu barangkali kita mesti harus melihat perfusion scan. Ini pengalaman saya sehari-hari.
Saya boleh menambah.
Iya, iya.
Saya nggak ingin menambah apa-apa sebetulnya, tapi sedikit komentar aja. Saya setuju sekali dengan yang tadi disampaikan oleh Dr. Munawar. Dr. Munawar adalah seorang panutan kita. Tapi biasanya kita harus menilai apakah di daerah yang ada CTO-nya itu